In this session, I will discuss one case which we have done recently. It's an LAD, chronic total occlusion, which we have done with Ipsilateral retrograde approach. So this gentleman is a 68-year-old known case of ischemic heart disease with old inferior wall MI, and his status post PCI with stent to RCA. But he had failed PCI to LAD in the same setting done in 2014. Subsequently, he was asymptomatic for 3 years, and he came recently with acute coronary syndrome with non-ST elevation, non-QMI, with normal sinus rhythm and good LV-RV function. We did an angiogram, which showed total occlusion of left anterior descending artery. So we can see here. So left anterior descending artery is totally occluded just beyond first septal and first diagonal with ambiguous entry, and it is filling from septal collaterals distally. So this is the left anterior descending artery, and this is right coronary artery, so which was normal. So there is a stent in proximal right coronary artery which is patent, and there is some disease in proximal PTA, around 50% lesion, so which we can leave it. So this guy came with acute coronary syndrome with non-QMI and failed CTO 4 years back. We will analyze this CTO with hybrid algorithm. If you see the proximal cap of the CTO, it is not very clear. It is an ambiguous entry point, and the entry point has two branches. One is first septal, another is first diagonal. We are not really sure where the entry point is for CTO. And if you see the length of the CTO, so the length is looking around 20 millimeters, so it comes in the long segment CTO. And then if you see the angle or angulation within the CTO segment, there might be no angulation within the CTO segment. It must be relatively straight segment. And when you look at calcium, so fluoroscopically there is no calcium. So, and collaterals, so there is a good septal collateral, so which is filling distal vessel. It's very good, almost we can say CC2 collateral. So, and distal vessel is quite good and big sized, and nearly looking around 3 millimeters in size. So when you put this into hybrid algorithm, and this patient also had collaterals from right coronary artery, so from PDA to LAD, as well as from PLVB to diagonal. So there are two types of collateral from right coronary artery to LAD, one to LAD, another is to diagonal. So when you put things into hybrid algorithm and analyze, so this patient has an ambiguous entry point. There is no fluoroscopic calcium in CTO segment and no angulation in CTO segment. It's a relatively long CTO, and there is a good collateral, and the distal vessel is pretty good. So it comes to JCTO score of 2 plus 1. 1 is because it is a reattempt, already failed CTO. So overall JCTO score is 3. So it would be a bit difficult case according to JCTO score. So, and what is the wiring strategy for this patient? See, antegrade, as the entry point is ambiguous, so we have to use an IVAS guided entry if you want to try an antegrade, or because we have a good collateral and good distal vessel, So it's almost CC2 collateral. So we can go retrograde either from septal to septal or retrograde from right coronary artery through PDA collateral. So as the septal to septal collateral is quite good, so we can also try ipsilateral retrograde. So these are the two wiring strategies, but as I'm comfortable with retrograde, I straight away went with retrograde in this case. In case if I start antegrade, I was guided entry, if this won't succeed, obviously again I will end up in a retrograde. But in antegrade, see, if we are successful in wiring from true to true lumen, so that is the end of procedure. But if your wire goes true to false, then again you will need either an ADR with crossbar stingray, or you have to go retrograde. So this would be optimal wiring strategy for this patient. So, but in this case, I went retrograde directly. I have not tried antegrade. I was guided entry. As the entry point was quite difficult to understand in IVUS because of the calcium, which I will show in subsequent IVUS films. So yeah, so this is epicranial view showing a good septal to septal collateral, and this is a 7 French guide into left system from femoral with a long sheath, and one wire is into diagonal just to give support to catheter, and with another wire and caravel. So this is a caravel catheter, caravel 130 centimeters, 150 centimeters, with a cyan blue wire. So I entered into septal collateral, and then so I we kept caravel catheter deep into the septal collateral, and then I took an angiogram, selective septal angiogram. So here we can see there is a good collateral. It's almost CC2, very good sized collateral. But if you see this septal artery is there is a layering of flow when I am injecting. So this layering is because same septal artery is also filling from right coronary artery. So probably even right coronary artery collateral is also a good collateral to come through and do a retrograde for this case. So anyway, with the cyan and caravel catheter, so I crossed septal collateral and I reached LAD, and then so I advanced caravel catheter into LAD, and we took an injection to confirm the position of caravel catheter. So now we can see caravel is through the septal collateral and then in the distal LAD after CTO. So now so I use retrograde wire escalation to cross CTO segment and reach proximal block and then into the proximal lumen of LAD. So once I crossed into LAD, I removed my cyan wire and I took a fielder wire just to check if there are any microchannels to cross. So this is a fielder wire. So fielder XTR. So it went up to the mid of CTO, but from there it is getting diverted into some kind of branch here. Probably there could be some small diagonal here. So it was repeatedly going into that branch. So then I shifted, I changed my wire from fielder XTR to Gaia 2. And this is Gaia 2. So Gaia 2 I could able to advance up to the proximal cap, but from here it was quite difficult to advance this wire beyond this point. So then I shifted to Gaia 3. So as the Gaia 2 is not getting advanced, and with Gaia 3 I could advance up to the proximal cap, and I checked my wire position in orthogonal views, and then I did an IVAS. So here Gaia 3 looked like reached almost my proximal LAD, and at this point I wanted to confirm wire position with intravascular ultrasound. Now you can see there are two catheters in LMCA ostium. One is just out of the ostium, other is in the ostium. So through the second catheter I advanced IVAS, and through the first catheter this caravel and retrograde wire was going. So I did an IVAS. What IVAS showed, I'll just show you here. So this is the IVAS from septal to LAD. This is a proximal LAD. If you see, this is the lumen and this is the IVAS catheter, and these are the this is the IVAS wire, and this is a caravel catheter, so which gives a huge shadow. This is a caravel catheter. So if you see LAD, this is a lumen, true lumen, but there is another lumen here. This is another lumen in the media. So my wire is essentially, it is in the subintimal location. So yeah, we can, if you can see, yeah, this is the wire. So this is the wire. So you can see the movement of wire also. I'll play. Now you can see, yeah. So this is the wire. So wire actually created a subintimal plane. It's a Gaia 3 wire. So the subintimal space. So, and this wire is not, despite repeated attempts, I couldn't direct it into the true lumen. So this is a fluoroscopic location of wire, what it looked like in IVAS. And you can see again the same wire location in IVAS. So this is a IVAS run from septal artery. So you can see there is a wire here around 5 to 6 o'clock, so which is in a subintimal location. So you can see the wire is here, and it created a subintimal plane here. So this is again same IVAS showing our retrograde wire. You can see this is our antegrade wires, septal wire through which IVAS was sent, and this one is the caravel catheter, which gives a large shadow, and this is a true lumen. And we are coming back into LAD from septal. Here you can observe, yeah, see, this is the wire. So this is the wire. You can just see, it comes and goes. So the wire is in the subintimal plane. So this is a true lumen and this is the subintimal plane. So now my wire is in the subintimal plane. So now we have to connect my antegrade true lumen to retrograde subintimal lumen. So we have to connect these two lumens. So once we connect, then we can externalize wire and we can do subsequent job. If you look at the IVAS picture, so this is the LAD, and this is a true lumen, and this is caravel catheter and wire through on which I was sent, and you can see this is the media. In media, this is the false lumen which is created by my wire. So this is a retrograde wire which came into false lumen, and these are all antegrade wires and antegrade caravel catheter and IVUS catheter. So yeah, at this stage, so what I did, say I have to take a antegrade wire. So I took an antegrade Gaia with microcatheter, and I tried sending Gaia wire into the proximal LAD for antegrade preparation. So, but Gaia wire was repeatedly going into diagonal. So, what I did, this is a second small diagonal. So, I passed this Gaia wire into the second diagonal. So, now you have one wire into septal and other wire into diagonal. So, and this crux is basically your LAD. So, what I did, so I directed my retrograde wire. So I took a pilot wire. So I tried directing my retrograde wire into this crux, but after repeated attempts I couldn't able to reach true lumen. So I advanced my antegrade wire, but as it was repeatedly going into Gaia 2, I shifted antegrade wire into Conquest Pro, so which gives me good control while wiring. So, and it's as well, it's a penetration wire. So there is a calcium at the proximal block in this patient, which I'll show you in subsequent IVUS. That calcium was preventing my Gaia wires or all antegrade wires, as well as even the retrograde wire, to come back into true lumen. So this calcium is directing all the wires subintimally. So I took a Conquest Pro, and this Conquest Pro I directed it into LAD antegrade. So with the repeated grid views in fluoroscopy, that's a rotational fluoroscopy, I gradually directed Conquest Pro down into CTO. And initially I tried kissing wire technique. So I directed retrograde wire towards my antegrade and antegrade wire towards retrograde. So this kissing technique, kissing wiring is attempted, but I couldn't connect with the kissing wiring. So I switched my strategy to knuckling. So retrograde wire knuckling. See, this is not retrospectively, I felt this is not an ideal strategy. Knuckling, retrograde knuckling is the last resort in any CTO case. It shouldn't be attempted as in early stages of wiring. But I did in this case. So I knuckled Fielder XT wire, Fielder XT-R, so in retrograde, and then I directed my antegrade Conquest Pro into the knuckle. So here, so almost my wire, Conquest Pro is into the knuckle in this cranial view, but when I took epicranial, you can see the wire is out of the knuckle. It's in a totally different plane. So by changing position of knuckle, I tried sending Conquest Pro down into knuckle. So these are the different views. So here what I am doing, so I am injecting through the caravel catheter just to check where my Conquest Pro wire is. You can see it is in the subintimal location. It's clearly in subintimal location. So, and my distal LAD is fine. So at this juncture, retrograde wire is going into subintimal plane, antegrade wire is into subintimal plane, and I'm not able to connect with the repeated attempts of kissing wiring, knuckling, and directing antegrade wire into knuckle. So all those techniques were tried. So what is the next option to connect these retrograde and antegrade spaces? So the best option, I have only two options. One is reverse cart. So another option is the cart. So in cart, so I have to send balloon through subtle collateral. So this is a very, it's a good subtle collateral, but there are a lot of loops in the subtle collateral. So sending a balloon for cart is not a first option. So I would always try reverse cart as a first strategy, then think of cart if this doesn't work out. But in contemporary CTO scenario, reverse cart is the most commonly used technique to connect antegrade and retrograde spaces. In this case, in initial attempts of reverse cart, so I couldn't able to advance the balloon over the antegrade wire. So as I told you already, there is a huge chunk of calcium sitting in the proximal block. So that didn't allow my wires as well as balloons, even microcatheter couldn't be advanced through the antegrade wire. So then I decided to do a reverse cart with the balloon on septal wire. So now, so if I fail in doing so, the backup was to do cart. So what I did is, so these are the various wire positions. You can see rotational fluoro to understand various wire positions, to connect. This is a retrograde knuckling and antegrade wire into the retrograde knuckling. So it's in rotational fluoro, antegrade wire looked like in knuckle. So, but I couldn't succeed. Yeah, I came to reverse cart over the septal wire as my antegrade wire, antegrade balloon on antegrade wire couldn't be tracked into the CTO. So you can see this is a balloon 2.25 into 15 balloon, so which I kept just across the septal, and I inflated, and then I directed my retrograde wire into this space. So it's a kind of reverse cart. So you can see in epicranial view, this is a balloon and this is a retrograde Gaia 3 wire, so which I directed towards balloon to connect into true lumen. So here my retrograde wire came into true lumen. Almost it appeared like true lumen. So I took different views. This is in epicranial, this is in areocranial, and this is alveocranial. And so then I advanced wire. You can see it's going along. So, and then I wanted to confirm where my wire is. So I took IVAS. You can see IVAS. I took IVAS to confirm where my wire is. If you see here, there are 3 wires. So this IVAS is exactly at the septal, close to septal. So that is beyond the diagonal in LAD. So there are 3 wires. I mean, you can see 3 wires. This is a one wire on which IVAS was passed, and this is another. You can see the broad shadow. This is the antegrade caravel catheter, and you can see the other wire. So there are 3 wires here with my one microcatheter. So which says my retrograde wire is in lumen. Then I also did IVAS and into guide. So you can see there are 2 wires in the second guide. So which again confirms my retrograde wire is came back into LED and then to guide. So then I advanced caravel into the second guide. So here you can see IVAS from septal to confirm retrograde wire position. So yeah, you can see this is the caravel catheter, and this is the wire on which IVUS was passed. And you can see at 6 o'clock there is a wire, and which comes and joins, yeah, you can see it comes and joins LED. Yeah, if you see, there is a lot of calcium in the proximal. This is the proximal cap, and you can see the calcium, and this is the exact reason why all the wires, either it is retrograde or antegrade, all the wires are going subintimally. This calcium is not allowing wires to pass through. That's why all the wires are going subintimal and creating subintimal space, both antegrade as well as retrograde. Now you can see this is the LED retrograde wire, which is crossing into crossing the block and then coming back into the LED. So this is a retrograde wire. So now the position of wire is confirmed. So it is in and then it is further advanced into the second guiding catheter, and then caravel is advanced, and RG wire is placed. And once RG wire is placed, then I took a 2 millimeter balloon and we did a pre-dilatation. And after pre-dilatation, we placed an antegrade wire. So here, see, I can do angioplasty over RG wire, but as a diagonal is deceased here, and as we had plans of even doing bifurcation, so we thought we'll place antegrade wire both into diagonal and LED, and then do further process on antegrade wire rather than RG wire. So that's why I placed an antegrade wire into LED, and then we removed retrograde wire, and then I checked septal from caravel just to see if there are any injuries in the septal collateral. So there was no injury in septal collateral. So then we started stenting LED. At this juncture, we analyzed, we took a check angiogram and analyzed, which showed a clear collateral from distal diagonal into the proximal diagonal. So as this diagonal was filling from the distal diagonal as well as from RCA with almost a TIMI3 flow, we thought we would avoid bifurcation. So we just did, and we took a 3x38 stunting, as I was showed distal vessel as 3 millimeter. This is a 3x38 Promus Premier, and proximal size according to IVUS was almost 4, so I took a 4/18 Promus Premier proximally with the overlapping stunting. And this is after stunting. You can see the diagonal is flowing, septal is flowing, and and this septal is actually this diagonal is actually filling the vessel. So yeah, so I'll just show you few interesting IVUS images after my pre-dilatation of LED. You can see this is the distal LED after lesion. It's around 3 millimeters in size, and if you see from here, so this is a true lumen which got compressed. This is a true lumen, and this is a false lumen. So almost from as I used knuckling, this is a problem with knuckling. So knuckle creates a subintimal space. My earlier retrograde wire was in true lumen. So once I knuckled retrograde wire, so I created a false lumen. So all my subsequent wires which I used for reverse card also went through the subintimal space. So this is the subintimal space, and this is a true lumen. So it's all along. It's I mean, my IVUS is in false lumen and true lumen is compressed. So and so this is all true lumen which is compressed and sitting on 3 o'clock position, and this is all false lumen. So in which my catheter is here. You can see clearly. So this is the false lumen in LID through which my IVS catheter is coming, and this is the septal artery. You can see. So septal artery is coming, and it joins LID, but there is a clear because of subintimal wire entered back into true lumen, and this is a reverse cart over a balloon kept into septal. So part of the dissection flap actually came in between LID lumen, LID created lumen into the over the septal artery. So now the septal is joining, and this is LID. Yeah, so this is an interesting IOS, and these are the fine little angiograms showing nicely opened LID, and and diagonal is filling clearly from the other diagonal, distal diagonal, and both septal arteries are very clear, so they are filling. Yeah, so this is a very interesting case, so which we have done with the ipsilateral retrograde approach. In fact, we have failed in this case 5 years before, as there is a change in wires and better microcatheters now. In fact, Caravel really helped in crossing these loops and completing these procedures. Probably Cyan wire and Caravel changed my intervention this time. Thank you.